I think we're there.
Hello.
Oh, this is very exciting, isn't it?
Very exciting to be chatting with you today about osteoarthritis.
Yeah, okay.
Which we only came up with doing this recently when we were together discussing SIRPA membership things, and we thought this could be a good chat.
Yes, absolutely. I think it's one of those things that is a sort of myths within society, and even still in some of the medical professions, as to how osteoarthritis and pain are or are not
Yes.
the same thing, that one leads to the other. We were just chatting just now before we came live.
Yes, I think
how do we know when we've got people on? They appear in the comments. So is it that we're looking forward to people saying hi?
Yes, I can see on the corner of my screen that there's 2 people with us at the moment. So welcome to whoever's out there. Please let us know who's there, and you can write on the chat box and post any questions or just say hello as we progress in our discussion on osteoarthritis. I'm sure it's going to be a good one. because like you say, it's juicy, it's quite contentious, and you wrote that brilliant blog, Catherine, just bringing that point of view through about osteoarthritis, and I'm sure that's got some juices flowing out there. So
yeah, it is quite controversial, isn't it, as to how some people view it, and how the science is showing that it's not as we think it was.
I know. Yeah. And it's interesting how science can do that. It's, because something can really appear to be what it is, and then the science can challenge that.
Yeah, but I think it's that history of where the science evolved over time, isn't it? Because I suppose when first people were getting, say, pain in their knee, becoming stiff and not able to use it because it was uncomfortable and getting stiff, that they took an X-ray when they had this wonderful machine, the X-ray machine, that could actually start to look inside our joints. And of course, when they looked inside the joints and onto the X-ray machine, they were able to see that the joints had these changes, which they eventually termed as osteoarthritic changes. And so whenever someone got a pain in their knee or their hip and they saw those arthritic changes, they just assumed that the pain that they were suffering with was definitely from those arthritic changes, osteoarthritic changes that they were seeing in the joint.
Yes, that's right. And that's because the biomedical world is trained in structure and looking for structure and disease that is physically obvious, rather than, because scans can't see learn neural pathways. Obviously, we're now getting functional MRI scans showing activity in the brain, which is different between chronic and acute. So we're getting better at being able to see the unseen a little bit and in the brain to help support the neural pathway things. But
yeah, you're right. The X-ray machine can only show you the bones, and we are very, very much more than just bones.
Yes,
so many different systems in our body, aren't there, that make us us.
Yeah,
each individual.
And we've got to take all the pieces of the puzzle, don't we? And I think what happens with osteoarthritis is a lot of the other information can be discounted because the image is so kind of magnetic to our attention that we can throw everything else out and just focus on that image. And I think also for the images, it's very strong impact, isn't it, on the patient when they've seen an X-ray of arthritic changes, which is what they're scared it's probably going to show anyway. That burns an image in their mind, and they've probably even got a photo on their phone which they share and look at and talk about, and that image is actually very fear-inducing, and the nervous system's going to be getting that repeated information that, look, there's something wrong here and I must protect from that image. It's a very powerful image, isn't it?
Hugely. And I know that if I had an X-ray done of my back, I'm absolutely convinced that I will start will see what's there, and it'll start to become uncomfortable and painful because I've seen, oh my goodness, look what's in there.
Yeah. Oh, it's only human nature, isn't it, to kind of have that awareness and then perhaps put more meaning onto it than is actually necessary, and fearful meaning onto it, for that matter. Yeah.
Fear is at the crux of it all, isn't it? Fear is at the crux of all symptoms that we get.
Yeah. Yeah. Well, we've got a couple of people with us. I wonder, even just with the people who are here, whether we could get a little feeling in the chat box. What do you think, Catherine, about where people are at?
Maggie, I've just read. My mate Maggie. Oh, welcome, Maggie. Oh, thank you for joining us. It's really lovely.
Oh, brilliant. That sounds good, and sounds like it's something they're very interested in by the sounds of it.
Yeah, and they're both watching. Oh, that's wonderful.
Oh, that is good. So I wonder if at this point people want to comment about the question of how much is osteoarthritic pain neuroplastic? And you could put in the comment box, none, there's no neuroplastic element. There's some, or it's all neuroplastic pain. So just to get a feel of what people are thinking at this point of the discussion. And
I wonder whether, would you be able to say what you'd see as the term neuroplastic pain? That might...
Yeah, so yes, that's true. So neuroplastic pain, referring to pain being caused by learned neural pathways and the brain, as opposed to coming from structural damage or disease. So, and that being which creates nociceptive pain. And I know it's confusing with these N words, isn't it? But nociceptive pain is pain that has come from the receptors in our body sending information to our brain, and our brain interpreting that as dangerous or not. And the nociceptors can be activated by inflammation, by physical trauma to the tissues, or infection. And that would activate those nociceptive reflexes and create a nociceptive pain response. But we know we can get pain from signals other than nociception, and that's what we mean by neuroplastic pain.
Yeah. So I tend to see it as that you've got the pain being within the brain, sort of the neuroplastic, and yes, it does involve the rest of the nervous system. And then you've got maybe the knee, or so let's go shoulder, because you can see shoulders here. The shoulder, say, arthritis signs that you see, and is it the structural or is it the neuroplastic nervous system?
Yes. So I thought
in my head I see this picture of the two things.
Yeah, that's a good way of looking at it. Yes, where the signals sort of coming from, and we experience the pain in our body. Of course, the pain isn't in our head. The pain is in our body, but we're talking about what is generating the pain. Is it inflammation? Is it structural damage or disease? Or is it learned neural pathways or fear pathways from the brain? So let's maybe think about what challenges the notion that osteoarthritis is the cause of pain when it's present, because there's quite a lot of evidence clinically and scientifically to challenge that notion, isn't there?
Absolutely, yes. So I think, Irralee, you were going to share a study, or you mentioned when we were chatting earlier on about people who'd had knee surgery, and
yes.
I mean, this might not have been early this morning, but when we spoke before, and they did some sham surgery. I know I heard it. The same story came up over the weekend as well when I was listening to
yes.
and
I love that.
Yeah, so people. Yeah, go on.
Yeah, so there are two really interesting studies which help challenge our beliefs around osteoarthritis pain, perhaps. So there was a trial of arthroscopic surgery. So that's the camera sort of surgery for osteoarthritis of the knee. Now, this procedure has been brought under question because of studies like this. This is in the New England Journal of Medicine in 2002, so a long time ago. And they randomly assigned 180 people to either having the arthroscopic surgery and debridement, so they kind of smooth all around the surfaces, a lavage, which means they just sort of flush it out, or they just have skin incisions, so absolutely no surgical procedure, but it looked like they had, sorry, I haven't done that thumbs up mark, I don't know why it's doing that. And then they followed up these patients and looked at their function and the walking and stairs and pain over the next 2 years. And what was interesting is everybody improved with this procedure. And at no point did the placebo group score lower in terms of function or greater pain. So the placebo group was at least as good at or better than the surgical procedures. Now, this really highlights the potential placebo effect of a surgery that when it looked like they had surgery but nothing was done, they had the same result as people who actually had. And in fact, the people who actually had the procedures actually had more pain post-op because there'd been more twiddling about inside their knee, of course. But ultimately, that settles down and the result was no different. But the people who got the placebo obviously didn't know they had a placebo and just had a renewed confidence in their knees' ability, maybe changed their beliefs and this had a big impact on the function and outcome. The other one we're talking about is evidence that's looked into outcomes for people having knee replacement surgery. And we're not saying people shouldn't have joint replacement surgery, are we? We're looking at all the different sort of presentations on that spectrum. But if you ask surgeons the outcome of knee replacement surgery, you might get a very, very different response to actually asking the patients. So this study looked at asking the patients. And there was 10 to 34% unfavorable outcomes according to the patient. And that's not including if there was an infection or loosening of the joint. Okay, so that is a different category again. So out of the people when there was an infection or loosening, there's still a 10 to 34% unfavorable, with 15% reporting moderate to severe pain 2 to 5 years post total knee replacement. And I guess this is not to cause fear or about knee replacement surgery, but just to bring up the question that how do you explain that if they don't even have a biological joint surface now, that their pain was still being produced? And I think we would see that these people have definitely got neuroplastic pain, that's what it was before the surgery, that's what it was after the surgery, perhaps, and that's why the surgery didn't give the relief. Or it could be that they had the surgery and then something happened in their life that created fear, uncertainty, or whatever about their knee and created the fear cycle,
then
created that neuroplastic pain afterwards. So there's all these different possibilities, of course. So and I know in myself I've seen people with osteoarthritic changes and no pain, lots of pain, no osteoarthritic changes, even within people with a lot of severe osteoarthritic changes on one knee, for example, milder ones on the other ones, but it's the mild knee that's got all the pain and the more severe one, no pain, according to just the X-ray results.
Yeah. So that's why we have to be so careful. Everyone has to be really careful about the X-ray results or the MRI results that they get. And obviously, MRI shows us more detail, more of the soft tissue as well in the joint and what's going on, doesn't it? But those normal abnormalities now we're seeing, and I think that's the follow-on from the history of the technology that we have. We had X-rays to start with. We then moved on to functional or onto MRIs. And they showed us those soft tissues of what was going on. We assumed that the symptoms that the person was getting in the early stages of MRI must be the structures that we were seeing. So the same sort of process that went on with the X-rays. But then when we started to do the research into people who had pain-free joints, so they had no problems, and then they were MRI'd in the studies that they were doing, they then began to see that quite a big substantial proportion of the people who had no pain had lots of abnormalities in their joints.
Yeah.
So we began to realize that actually these abnormalities we're seeing, they are not just directly what's causing the person's symptoms, that these abnormalities that we see in the joint are fairly normal. And, you know, we get wrinkles as we get older, and we get grey hair as we get older. And we now think of those sort of structural abnormalities, those osteoarthritic changes in the main, are just part of what happens as we get older. They are like skin wrinkles or grey hair on the side.
And in fact, they can be considered as clever, adaptable changes to loading in the joint. So the joint you might be experiencing more loading, so it increases its surface area by creating osteophytes, and that's to share the load, to maybe view it as adaptive changes, which can change the biomechanics of the joint and create a situation where the joint's got less range of movement because of the physical changes in the joint. But just because the joint changes its physical shape and therefore its physical range doesn't mean that those factors create pain. There's something else going on in addition to that situation. In fact, there's been studies that show no correlation between the amount of osteoarthritis and the presence or absence of symptoms, with up to 50% with osteoarthritic changes having no pain. So it's a significant, it's not just like a couple, it's a significant proportion going on. And we seem to have, in the mind-body world especially, become more happy with the sort of osteoarthritic changes in spinal x-rays. I'm thinking, yeah, they're normal abnormalities and we don't give them so much fear. But when it comes to peripheral joints, the joints that we can see, there's a much sort of less ability to maybe accept those as normal abnormalities, probably because we can see that our joints look different in shape, and you know, so there's that ability.
Yeah, with the knee, because it's there, it's right in front of you, and it's a fairly bony structure as such, isn't it? And you can easily see those bony changes in the knee. So it's so easy to think, oh my goodness, what's happening? You know, I can feel it's changing shape. There must be something wrong, and it hurts. Oh my goodness.
Yes,
but
exactly.
It's that underlying belief in that there's something wrong, not just wrong with the joint. It's we're not understanding the normality of that, and that's a grey hair. that's not.
Yes,
it's a wrinkle, a big wrinkle in the joint.
We're putting that fearful meaning on it, particularly because osteoarthritis is considered to be wear and tear, which most people then believe, well, that means I shouldn't use my joint so much. Now, this puts a mechanical machine concept onto the body, where if you use a machine a lot and you keep using that part, it wears away. But a machine is not a living, adaptable tissue. It's not alive. It can't respond to that load. So you do wear it out when you keep, you know, hinging a machine. It does wear it out. And we're used to looking at our bodies like machines, but we're not machines. We are very different to that. And we don't wear out the more we use. In fact, it's the more we move, the more we improve.
Yeah, it's completely the opposite, really, isn't it?
Yeah,
but we want that because it's a lot of things, that normal curve that you learn about in maths, the bell curve. There's that lovely section where you use it, you know, a moderate amount, a lot, but you don't want to go to the extremes at the other end. If you underuse it, underload it, never move it, then that will cause more changes to occur to the joint. Not necessarily pain, but changes to the joint. Yes. And then at the other extreme, if you really overuse a joint, I mean, that's really excessively overuse a joint, beyond the marathon running, because they're probably still doing it, you know, well, they're giving themselves enough recovery in their training and stuff.
Yes, we need that recovery time for the tissue to adapt. Yeah, that's right.
Yeah,
and what's interesting is that the cartilage that lines the ends of all our bones, the joint cartilage, not the meniscus. We're talking about knees, because knees are the most common and disabling place for osteoarthritis. But we appreciate, you know, insert the word hip or toe or thumb, you know, or shoulder appropriately. But
where I spotted, so we need to have a look at the. Sorry, carry on. Anyway.
Yes, we will. So yes, so the articular cartilage, which is the very clever material which creates that buffer between the end of the bone, and is what we can't see that on X-ray, but we can infer its thickness by how close the joint surfaces are, and that's right, that sort of gap in the joint. And what's interesting is that the cartilage lining on the bones doesn't have its own blood supply. So it absolutely relies on tissue compression and loading and movement in order to receive its nutrients and to receive it to be healthy. So when you don't load it, it actually becomes softer and less shock absorbing in the body. And they've shown this even more acutely when astronauts fly out to the moon or wherever else they go. They have done tests on them and find that their articular cartilage thins because they haven't got all that weight bearing going on in that reduced gravity environment. But that when they come back to Earth and they start, using their joints again, then that thickens up again. And they've also
that's really important to know, isn't it? Is that cartilage can regenerate. Yes. Again, I think that was a bit of a myth from the past that we thought as the cartilage thinned, well, it's tough, you can't do anything about it, but cartilage does regenerate.
And that's also been proven by studies of marathon runners. They took MRI scans during a series of marathon runs, like people marathon running on successive days, and to see, because the old theory would be, well, the more you run, the more you wear it out, it's going to break down as you go on. And what they found was the articular cartilage actually strengthened and thickened throughout this period of running over several weeks, marathon distances. So I think that really is flies in the face of that myth that the more I use it, the more I wear it out, and so I should avoid activity and preserve my joint. But that's when the downward spiral starts, doesn't it? When people start going off that way.
Yeah, and it's a misunderstanding leading to almost to a misbelief, and the fear sets in, and therefore you don't use the joint, you protect it. The muscles, because you're in fear, your muscles tend to tense up a little bit. That sort of keeps the joint more stiff, because that will influence some of that stiffness, is that co-contraction of the muscles either side as well. And then, as you say, then go, oh, this is something wrong with my knee, and you use it less, it gets more comfortable. And as you say, that's that spiral of becoming towards less able to use your joint, and yourself becomes less functional as a whole person.
And inevitably that spiral gets to a point where the only thing you can do is have a joint replacement when it's got down to that severe level of disability, and which it can do once it goes on that journey. They've done studies on people who've been on the waiting list for joint replacements, and they've done sort of rehab, and people have avoided having surgery, people have improved. But when they look at rehab in isolation, so just doing strengthening, for example, they estimate you can get about a 35% improvement. So it's not the full story just exercising, and that's where the mind-body approach comes in, about rewiring conditioned responses, changing beliefs, and dealing with the other reasons for pain that are creating stress and fear in the nervous system, which is what we do, and which is where the mind-body approach can be so valuable in helping people with osteoarthritis.
Absolutely.
I'm sure you would agree with that.
Yeah. And I think that's being in awe of your body. It's starting to change from being in fear to completely the opposite, that how amazing is it that our bodies can do all this adaptive changing right the way through up until the end of our lives, so to speak, isn't it? We are still able to strengthen muscles, strengthen bone, help cartilage, get movement back, and obviously we say, reduce pain with the mind-body approach. But we really need to change our way of thinking that, my goodness, our bodies are just incredible. From the the fact that we don't have to think about breathing, we don't have to think about our heart working, all the stuff that goes on in our liver, and all the different organs, and our brain is just incredible. That I think it's likely to swap wow, we are incredible. Our physiology is incredible, and being brain and neuroplastic pathways as well. I still see that as physiology. It's not some imaginary thing going on.
No,
It's physical lighting up of various pathways in our brain as we think and feel.
Physiological. That's right. But we're not talking about psychology. We're talking about that physiological neural pathway, stress physiology, and it's about the meaning we put to the pain. So I'm going to look through some of the comments here. I'm just looking at the bottom, but I'll make my way up. But Liz, thank you for your comment, has said that, is it okay to keep walking, exercising if you're in pain from your knee? Well, that depends on what you believe the pain in your knee means when you're walking and loading. So that's when the education about pain, osteoarthritis, the value of walking, expectation effect, condition response, all these sort of changing what you believe it means when it's hurting. Is that fear? Or, because it's obviously our body, like you just said, Catherine, is much more resilient and stronger than we would believe. And our mind is also much more fearful than we would like. And those two things combined can create a greater pain experience. But we can tackle that with the information about pain and about osteoarthritis. And of course, if we're doing anything when there's pain, we want to, that's when we can bring in things like visualizing an activity, just like we would for any other chronic pain. Let's say you had knee pain and you didn't have osteoarthritis changes. You would approach this in that way of visualizing the activity and being pain-free and joyful, and changing that association in your brain about how safe it is to do that activity. And then being able to build up doing that exercise. And success isn't absence of pain, it's absence of fear about the pain, and just starting where you are at a smaller amount to gain your confidence, and then getting some corrective experiences and building on that, and being open to the fact that I can challenge this pain that I think is coming from osteoarthritis by using this same approach from the mind-body way of thinking.
Yeah. It is that bit by bit by bit, isn't it, of upping your exercise level, that you find out what you are able to do, and sort of almost like make a plan, and maybe do your walking, whatever you're able to do at the moment, but the next day to just to do a tiny little bit more, and do that for a day or two, and then up it and do a little bit more. And it's as you're doing that, you're making those physiological changes to the body, in the sense that you're strengthening muscles, you're getting the joint moving, you're helping the cartilage with that movement that you're doing. So that you're helping the physiological structure of the joint, and of the whole of you, of your leg, for example, if it is your knee, I think you were talking about. But you're also proving to your mind that it's okay, I did do that, it's okay, I can do that. And you're starting to dampen the fear response down by very gradually increasing the amount that you do. It's called graded exposure. So you're gradedly exposing your joint and your body to more, but also gradedly exposing your mind to that actually it's safe to do this. And so you're reducing the fear. And I think it works in by doing this graded exposure, it works at both extremes.
Yes, it does. And Esther, thank you for giving me hope. I was told it was going to get worse. And that is unfortunately a big nocibic message that people get from health professionals and Dr. Google, that if you've got osteoarthritis, it's only going to get worse. And all that fear and that generates, which ups the pain level, creates more distress. And it's just not true, by what we've already discussed about the evidence showing that the body can adapt and change and improve with this information on board, isn't it?
And I think we have hit. Sorry, go on.
No, you say.
I was just going to say we remember our grandparents, maybe who were diagnosed with osteoarthritis in maybe the mid 1950s, 60s, whenever that time is. I can't work out when they were around, when x-rays, I don't think MRIs had started then, had first come around, and they were, oh no, and it's only going to get worse. And we've still got those stories in our memories, haven't we?
Yeah.
And so then when we get the diagnosis, we can't help but flip back to, oh yeah, I remember Granny having that, and she couldn't walk, and it got worse, and then she ended up in the stories. But we now know differently.
Yes.
We've moved, we've got the science.
Yes,
And
science.
yeah.
Well, I have to say hello to Frankie, who's calling in from Australia. Yay! I got to say hello to that. I don't know what time of the night it is there, 11, 10, or 9 p.m. at night, perhaps, something like that, 10 p.m. And I also responding to someone saying, and to Jean saying she's just returned from a GP appointment with big toe arthritis, has recommended steroid injection, but have been doing work on mind-body pain. So I'm conflicted as to whether this will help with the ongoing pain. And I think this brings to the question of inflammation. And the important thing to point out is that osteoarthritis is not considered to be an inflammatory joint disease. But we can get acute inflammation in a joint. So inflammation looks like swelling, redness, heat. That's all the sort of white cell activity in there working with the inflammation. And that's what we would see with gout or rheumatoid arthritis or lupus or these inflammatory joint diseases. And these inflammatory joint diseases, the pain is being created by nociception. So that inflammation is sending messages up to the brain, which is eliciting that pain response. So this is nociceptive pain. That's not to say they don't have elements of neuroplastic pain in there, but the inflammatory part needs treating in these conditions, and they respond well to steroid injections, anti-inflammatory, and immunotherapies that treat these inflammatory joint disorders. But osteoarthritis is being considered to be more maybe a micro-inflammation whole body response to which can happen in response to prolonged stress and creating pro-inflammatory cytokines. And what I've understood about cytokines, they're actually an immune protein, and they act in the brain and in the spinal cord, and to modulate, sensations coming up from the body. And Dr. Howard Schubiner, whom we know in the mind-body arena in America, he would say that something isn't due to inflammation if the symptoms can change quite quickly, because inflammation can't change quickly. So if you're doing somatic tracking with someone, or their pain is different at different times of day, or there's sort of real discrepancies in how the pain is behaving, that inflammation can't switch on and off like that, and pain can switch on and off like that sometimes, or move around. And if it's doing that, it's more likely to be coming from neuroplastic mechanisms than inflammation mechanisms. So in response to having an injection in your toe, Jean, if it's acutely inflamed, if it's swollen and it's red and it's looking inflamed, then a cortisone injection would be helpful and would be supportive in any of the mind-body work that you're doing. Of course, it could also be helpful in the sense of it can offer a placebo response. And again, there's been studies on the effects of cortisone injections for osteoarthritis in a double-blind, randomized, controlled trial, which is like the gold standard of working out what this is. And this is in, they did injections of knee arthritis and showed there was no benefit compared to saline injections. And in fact, there was a significant difference in knee pain 2 years down the line. So, and maybe that's because osteoarthritis isn't an inflammatory problem that responds well to that. You might get a placebo effect, and maybe that's desirable. They usually only recommend you have a couple of cortisone injections that has been shown to reduce the cartilage volume, the articular cartilage volume, with repeated steroid injections. So usually that's why if you are offered those, you're given just a few to preserve the joint. So it's not that it goes against the mind body, it's whether it's indicated because of acute inflammation being present, in which case it would be very helpful. But if there's no evidence of acute inflammation in that joint, even if it gave you a period of some less pain, it might give you a window to help you gain confidence in loading and help your mind-body understanding be put into action. What do you think, Catherine?
Yeah, it's interesting, isn't it? When it's understanding that difference between obvious inflammation, as you said, swelling and heat, and that macro inflammation from one of the RA you said, or gout or something when it comes to the big toe. But if it's osteoarthritis, it's that itis bit at the end of the arthritis is rather throwing our understanding, I think, because it's a different form of inflammation. As you said, it's micro inflammation, which is a whole, it's related to microinflammation in the body as a whole. It's not a big inflammatory process that's going on in that joint itself. And it's understanding the difference, I think, isn't it, between the two? I guess in a way, when you got to make that decision, it has to be a very personal decision about whether you go ahead with the steroid injection or not, and that is chatting it over with your GP, because he might say, well, if you understand a bit more about the mind body and you want to spend some more time doing that, then we can defer the possibility. But that's not knowing whether you can wait 6 months, to spend more time with the mind body approach, and can you then go back and talk to him about it then? I would imagine that's possible. I haven't worked in the NHS for a little while, so and it's COVID, I think things are perhaps a little bit more challenging with regard to, I don't know how that works, but
so that's right. I think there's different options to consider. And the good news about it being microinflammation is then it can be related to being in that chronic stress response, creating those pro-inflammatory cytokines that come from the nervous system being in a chronic stress response. And then you can direct your attention to tackling this microinflammation through the nervous system, through regulating the stress, through resolving unresolved stresses and emotions, which are triggering this microinflammation response throughout the body. And that's what the mind-body approach does. It works on this microinflammation that's in the body as a result of the physiological stress response being turned on chronically. And that's where so much value could be had from doing this approach with an osteoarthritic presentation.
It is difficult. It's not so, understanding this is I think quite a challenge.
It is.
Do you not agree?
It's
it's
complex.
Of inflammation here, but I suppose in a way, if you've got this arthritic changes that have been diagnosed by your GP in your toe, you could almost see that as an opportunity. Right, I've got that diagnosis. I know it is only osteoarthritis in my toe, if that is what you said it, because you put arthritis, but if it is osteoarthritis, then this is a wonderful opportunity to actually spend more time focusing on the mind-body approach. And as you say, looking at your stress levels, looking at the fears that you're going through, and all the different strategies that we talk about in the SIRPA approach, in the mind-body approach. It might be a wonderful opportunity. Right, let's home in on this and see why I've got this inflammation going on in my body that's affecting my toe, but the whole body as a whole, the body as a whole.
And that's becoming curious about the behavior of the symptoms, isn't it? Not just looking at the diagnosis. So I'm sure you as well, Catherine, have come across many patients who might have really arthritic toes or hands or even knees, other joints, and they don't have pain on there all the time. They might intermittently have pain. The osteoarthritis is there 24/7 all the time, but they might have periods when they have pain in that joint and not. And they'll probably pin those times of pain on some physical reason because that's what we're conditioned to believe. Maybe I overdid it and that's why I got pain. Maybe that is sometimes the case, but maybe it's, if we look more widely, like we do encourage with the mind-body approach, what was actually going on, what was stressing your nervous system in that situation when that joint pain flared up, what was going on then? And also to notice the exceptions to the rule. So I had, knee pain in this situation, but when I'm in this context doing this activity with this person, I don't have much knee pain then. Well, the osteoarthritis is still there. That's not changed. What has changed is the level of fear in the nervous system. And then that can give you clues as to how neuroplastic your pain is that you're experiencing in the joint. And to become curious about that and not just be fixated on the X-ray result, but to think a bit more broadly about what's going on for the nervous system, what's going on for you inside you and in your life around the time of your symptoms starting or being increased or decreased for that matter.
Okay. It's looking at you and your life as a whole. Where's the stress? Has it changed? Yeah. And sometimes I think when people go, oh, I haven't got stressed, I'm coping. If you feel like you have that way of saying that I am coping, you probably are coping because you're possibly pushing down a lot of the stress that you're feeling and not necessarily dealing with that. So I sometimes think we misinterpret the fact that, oh, it's fine, I'm coping, is actually the time when we are doing brilliantly at keeping going, but we're to the detriment of ourselves as a whole because we're pushing down those emotions. We're not taking care of ourselves. We just want to push on, keep going. So we get through functionally what's demanded and asked of us, but that's not actually necessarily helping us as a human being. And we're pushing the stress inside, pushing the fear inside, and then it comes out maybe in a joint, in a big toe, in a knee, in a shoulder instead.
Yeah, exactly. Liz is saying that the consultants recommended physiotherapy for osteoarthritis. Is this a useful way to go? And I think, a lot of physiotherapists now would adopt the approach of, helping people become more functional, more physical, and giving those sort of strengthening exercises. They may or may not, they may have the pain science information as well, and in which case you be able to benefit from that. I just want to at this point point out this book called The Knee Osteoarthritis Handbook, by Lorimer Mosley, David Butler and Tasha Stanton, who are Australian physiotherapists and neuroscientists in the pain, and they've produced that handbook for patients, and they challenge the local joint concept of osteoarthritis, as we've been talking about. They don't take it as far as the mind-body approach, but they're sort of halfway between in terms of the pain science and reducing fear and how healthy it is to load and move our joints for their health and for reducing pain. So there's a lot of really good information in there for sure. So if you go to physio and if you ask them questions about, is this going to get worse, or, you don't know what's going to come back because you don't know what that physio's approach might be. But certainly having guidance to be given exercises, rehabilitation, functional exercises to help you maybe gain confidence in using your body again, and having someone to help give you advice on how to build up your walking or get back into activities you might be avoiding, and giving exercises that can kind of challenge your fears and expose you to better loading movements, and being able to move without bracing your body, tensing your knee or your hip or your shoulder as you move, which just creates more compression and dysfunction. So the physio might be able to help you move in a more relaxed, normalized way, which will also help pain. So yes, there can be some benefit with that, even if they don't have the mind-body approach. You can do that in conjunction, I would say.
Absolutely. It is that functional return of movement that's most important, rather than perhaps the hands-on massage that can be alleviating in the very short term, but you really need to be getting the function, the movement, the strength gradually back with the guidance of your physio. It's that graded exposure that we were talking about earlier on, giving you confidence back in your joint and in your body, as well as getting the physical strength and helping that cartilage to get better.
Yeah, that's right. So I think you can use a combination. And like I said before, they found rehab alone can maybe have a 35% improvement. So it can certainly give you some improvement, but coming from a mind-body space, you realize you can even get even greater improvement potentially. You apply that as well.
Yeah. And I think sometimes when I work with people, I encourage people to do the mind-body work almost first, and perhaps doing visualizations of them being able to do those movements comfortably, of, you know, what is it that you'd like to do in the future once their symptoms have settled? What is it that you're going to be able to, what would you like to be able to do? And you're sort of visualizing yourself in a really lovely setting. It doesn't, you know, it doesn't have to be reality. It can be imagined as well you'd like. And the whole is you're training your brain. You're producing new neural pathways in your brain with your imagination and with your visualization. So you're giving your brain new options, new pathways that it can go down, so that when you do start doing the movements and doing your rehab, then your brain's already sort of set up. Oh, I know I could do that in visualization. You've got less fear going on, and therefore you're able actually to move more comfortably when you do return to the actual movement itself.
Yeah, absolutely. And I think it's also, like all mind-body conditions, changing your relationship to that joint. So you might be if you consider how you feel about your knee that's got osteoarthritis, and you may realize you may be annoyed at it or frustrated at it, or kind of, got a little bit of a negative relationship with that part of your body, setting up and perpetuating that fight flight kind of enemy within dynamic in your nervous system. And instead, maybe being able to turn towards that joint that's working really hard to help you be functional, and consider turning towards it in a more loving, compassionate, appreciative kind of way, just changing that fear response within the nervous system towards a part of your body which, instead of seeing it as something that's going wrong and is broken or not good enough, as seeing it as it's the changes that have happened are adaptive to the loading it's experienced, and that's good. That's your clever body doing those adaptations, and to really reframe how you perceive those structural changes when it's due to osteoarthritis as actually adaptive, and not something to get rid of or perfect or correct necessarily, but more the meaning you're putting to those changes, which we've talked about.
Yeah, the living tissue is adapting to help you. Yeah. Yeah.
Also, is it worth talking a little bit about diet as part of the picture as well? Because, like we say, there's so many different aspects that feed into the whole body person. Anything you'd like to say?
Yeah, because I think my understanding is it's that if you think about the way that your gut works, if you've got the healthy bacteria in there, the less of the bad bacteria, which depends on the food that we eat. For instance, we all know what we should be eating, and I know it's a challenge constantly to eat the right things. But the science is showing this. If we're not eating the right things, then we get these little gaps between the cells in our gut. And this is me talking as a layperson with regards to diet as such, just someone who's interested in it. It's not my we're physiotherapists, not nutritionists. Yeah. But from my understanding is that we by getting these little gaps through the food that we're eating, or the wrong food that we're eating as such, which we weren't evolved to take on board, we're getting little bits. And I think I've forgotten what his name is. He talks about little particles of poo are ending up in our bloodstream, and it's our body is therefore responding to these tiny little particles that shouldn't be there, and they're seeing them, and that's one of the things that's giving us our that sort of very micro background inflammatory response, which is affecting our bodies as a whole, including the joints. Would you agree? Is that what you meant, Irralee, when you were
Yeah.
asking?
Well, I think it is a factor, but we want to put it in proportion. We don't need a perfect diet to be pain-free. We want it to be mostly good. I always think of like an 80-20. So if our diet is 80% whole food, it's the 20% that we don't want to really have greater than that, particularly is highly processed food, high levels of sugar, large quantities of red meat, and all these things create a stressful for our body to process. So it creates a physical stress on our body, which then contributes to the physiological stress response, which then creates this chronic microinflammation. So by nurturing our body with the nutritious foods 80% of the time, then we're actually creating a healthier environment for our cells and nervous system to operate in. So and we also know that smoking and alcohol have pro-inflammatory effects on our system because of the stress it creates in our nervous system and in our body tissues. And so by removing these extra sources of stressors in our nervous system where we can, then we lower this microinflammation that's throughout our body, and therefore we reduce the sensitivity in our nervous system to the normal loading that's being fed through our spinal cord and into our brain as it's assessing whether it's safe for us to move or not. So I think all these things do have an influence, but we don't want to get too extreme in anything that we do. Keeping that balance is important, isn't it?
It's sort of desensitizing the joint, isn't it? By looking after yourself as a whole, yes, including diet and sleep being a very important factor in keeping our stress levels down and making sure that we have those nice, or as best as we can, routines for sleep. Yes. And I know the things that I've always been encouraged to do is making sure we get some morning sunlight. That blue light in the morning, that has an effect on the way our hormones work and helps us to sleep the following evening or following nighttime. Making sure that we turn off devices a couple of hours at least before we go to bed, so that we haven't got that activity going on our brain, that we're beginning to wind our brain down a little bit so that we can sleep better. Not that it's not having that blue light that's coming from the screen, and you can get glasses and things, can't you, to help protect your from the blue light from screens in the evening. And even children, isn't it? I know we're talking about arthritis, but osteoarthritis, but it's that children having to do their homework on screens now all the time has become a bit of an issue as well, isn't it? Because that's not helping them to get to sleep in the evening. So it's quite an important thing that we are firm with ourselves, with our children.
That's right. Our nervous system to go to sleep needs to not be all overstimulated and adrenalized. And so apart from the sleep hygiene type things, we also maybe have to consider what we're not dealing with in our life that is creating that ongoing fear pattern in our nervous system. So this is where the sort of journaling techniques or the emotional awareness and expression and being able to deal with the stressors so that we can express how we feel about them and come to resolution with these issues, which will then take them out of our nervous system, so our nervous system can come down out of that fight and flight response. So yes, all these different things. I've just noticed there's some people we haven't got to, I want to get to in the last few moments that we've got here. Frankie has said that they've had a lumbar laminectomy for spinal stenosis and that they have severe osteoarthritis in the facet joints. Mobility is good, but I have chronic sitting pain, worse in the evenings. Mind-body techniques have helped, but is there any chance I can eliminate chronic pain, or is some of this pain structure? So again, the fact that your mobility is really good and that you're, when you're loading and moving your facet joints around, that you're feeling so much better, then that's really good news. The fact that you're getting pain with sitting in the evening, and it's more in the evening than other times of day, again, could be a sign that the symptoms could be neuroplastic. And that the other thing to know, that when we're sitting, our facet joints are pretty unloaded in that position. So I would suggest that they're probably not the cause. That structural change is probably not the cause for your symptoms in sitting. And to be more curious about maybe some beliefs about sitting, and looking at the exceptions to the rule, that you might have been sitting in the evening in another context somewhere else, and what was your pain like then? So become curious for other reasons beyond the structural, and see what information or evidence would point you more towards there being that neuroplastic element that you could work to resolve, because you can't change the structure any further than you've had the changes for. But the good news about neuroplastic symptoms is we can change them. Yeah, so that's
Absolutely
a possibility.
Yeah, because if you can sit in that same place that you're sitting in the evening at a different time of day, and it's not such a problem, that is sort of, pushing towards the neuroplastic symptoms, isn't it? Which are changeable, mind body changeable.
Yes. So all of this is possible. Anything else we haven't covered yet? It's such a big topic, isn't it?
And I was looking at some of those other things. That pain was in my right shoulder, but the X-ray showed that the left shoulder was worse, which is what we were saying about those, the X-ray findings.
Yes. I had the same. My mum had both her knees X-rayed when she had pain in her right knee. Her right knee showed mild to moderate osteoarthritis. Her left knee showed severe osteoarthritis. And so she actually had her right one replaced. And the surgeon kept asking her about the pain in the left knee, because he couldn't understand that there's not a correlation between the X-ray and pain. And she had no pain for the next 10 years in this left knee, despite severe degenerative changes. She has got pain there now, which started over COVID and for maybe other reasons other than the state of the joint. But there's a real mismatch between osteoarthritic changes on the scan and pain. So I don't want people to be overly concerned by the scan changes, as we said at the beginning of our chat here, because there's more elements going on than just that.
It's a whole body approach, isn't it? Osteoarthritis is a whole body approach. Yeah. So that, because Shaheen earlier on said, diagnosed with osteoarthritis, can pain still be helped with mind-body symptoms? And hopefully we've given you the encouragement that yes, certainly. Yeah. Working on the whole body, mind and body.
Yes. So I hope we've created some curiosity there and some discussion amongst everybody about osteoarthritis and neuroplastic pain and the relationship between them. Have you seen another question there we've missed out on?
No, I'm just whizzing through.
Oh, someone's asked, Frankie, is spinal arthritis the same? Should we think of this as the joint adapting? Yes, just the same, whether it's a spinal joint or a knee joint or a finger joint, adaptations to loading over time.
Yeah. Oh, look, my physio's just finished her SIRPA training. That's great.
Oh,
so very lucky.
Oh, well, then you can go. You can go for that. You can definitely go for that physio. Then your quid's in there.
And someone talked about, if natural remedies do work. If they didn't, we wouldn't have used them for thousands of years. Exactly. It's the arrival of maybe thinking our talk today. The Industrial Revolution has changed us to thinking we are machines.
Yes.
Whereas before we had machines, we just didn't think like this at all, did we?
No, before we had machines, we found other ways to help with our pain, and a lot of them being herbal or other mechanisms. And yeah, we've lost that because we've put a lot of importance on technology, and we've lost the wisdoms that generations before us and societies around the world have experienced.
Yeah, and it's trusting your body. It's learning to listen into your body. And I do say my husband and now my son and now my daughter this morning said she'd like one. We've got one of these Garmin watches, which is giving all the feedback about what's going on in your body. There's lots of positives, I'm sure, but also I think they're using this to decide whether they need to move. My husband comes out and goes, oh, I've got to move, which is lovely as a reminder, but he's not listening into the body. And I just wonder that in another 10 years or 20 years, that we'll all be so stuck with our data coming from our watches that we'll lose even more of what's going on in our body. We need to sort of get that felt sense back. That
that's
we as
a big focus, isn't it?
Really important.
Yeah, that's a big skill and strategy we encourage with the mind-body approach, is tuning into the felt sense, tuning into the body, tuning into what the body says. And you can tune into a joint and ask it, what does it want to say to you? I had a patient this week, she was tuning into a part of her body, and to her surprise and mine at the time, because you never know what's going to happen, this body part did speak back to her, and quite revealed what was going on that was producing this pain. And in this case, it was that this body part felt like it was under a lot of intense pressure, interestingly. So you can, with your somatic tracking, be curious and ask that tissue, what is the message, or what are you trying to communicate? And just don't go into your head for the answer. Just wait and see if something pops up. It could be an odd word or a memory, or an emotion. Just something might pop up, and that's part of that pause, breathe, feel strategy. Just tuning in and getting the information from our body. Rather than relying on technology all the time, getting a balance from the technology, using the technology where it's helpful, but not fully relying on it. Yeah, that's right. It's not that we're not anti-technology, we're not anti-surgery, we're not anti-drugs or anything. Yeah, getting that balance. All right. Well, I think we've come up to the end of our hour's little time together. Thanks, Catherine. It was really fun.
It was really nice to do it. Really good. And lovely to have so many people on the line. And feeding back and giving our examples. Yeah,
really good to get people's comments, and we've enjoyed having you join us on the chat, and I hope you found something useful for your own situation from that, or at least maybe create a bit more desire to dig a bit deeper into what might be going on in your pain. A bit of curiosity is always a good thing, isn't it?
More curious, yeah.
All right, then.
Thank you.
Leave you all to it. And what was it that we need to do? Not wear and tear. We've got to move to improve.
Move to improve. Absolutely. Love it.
All right. Bye for now.
Bye.